But now oftentimes, like, your patient example is from Marlton, right?
Mhm.
And she was previously potentially, thought about getting sinus surgery that's more big and more aggressive, done under general anesthesia. She was able to get her procedure done in a more minimally invasive way in the office setting. Now, it's not for everybody, but for some people, when the anatomy is favorable and you can get things get it done in the office, it's probably preferable to do it that way. Hello, everyone. This is Dr. Reddy, joined with Dr. Smith. We're coming to you with another episode of the We Knows Noses podcast. And today we will be going over a case example of a patient that came into our office and had a problem that wanted us to evaluate. So I'll let Dr. Smith start off with our case example.
Sure. So I had a 50-year-old woman from the area here in Marlton, New Jersey, who came in complaining of some postnasal drip and some ear fullness in one ear. No major history of any sinus problems or reflux problems, but had this ear pressure and postnasal drip for several months and just wasn't seeming to go away. She had a recent upper respiratory cold type thing, but nothing major that she thought, was out of the blue. And so we did a thorough history and physical on her here in the office. And of note, during the exam, we noticed that one of her turbinates seemed to be kind of moved out of normal position and kind of up towards the lateral part or towards the orbit of the left side of her sinus cavity. So we ended up doing a CAT scan of her sinuses after trying things like nasal steroids, which you've heard us talk about to try to decrease inflammation. And lo and behold, we found something called a chronic sinus infection that we often call a silent sinus infection, because patients don't typically have a lot of the severe pain, pressure symptoms that we all equate to an active sinus infection. And her middle turbinate had been kind of suctioned, as well as the frontal recess. So the area coming up into that frontal sinus, the one above your eye, was all kind of suctioned closed from years and years and years of obstruction, leading to this, quote, silent or atelectatic sinus of the frontal sinus. So we then set her up and performed an in-office balloon dilation of the frontal sinus, including the frontal recess, removed a couple of the anterior ethmoid air cells, and she had a phenomenal response to that. Stood up, walked out of here, went home same day without a major recovery, and minimal bleeding, minimal pain afterwards, and really almost little to no lost work. So one thing I wanted to bring this result up for was to discuss some of the lesser known reasons to do sometimes these sinus procedures. So Dr. Reddy, do you want to talk a little bit about what it typical, this is an atypical example, but what kind of a typical silent sinus that we see?
Yeah. So, most people that have sinus issues, they have symptoms of facial pressure and congestion and runny nose, maybe changes with their sense of smell and taste. Those are the typical symptoms, but people with silent sinus syndrome, they may get those atypical symptoms. And sometimes these patients can be asymptomatic, have no symptoms at all. And they might get a CAT scan or an MRI for a different reason. And then, maybe a headache or something like that. And then it shows up on the CAT scan. So sometimes these patients have no symptoms. And other times, patients may have very subtle symptoms like what you're describing, maybe a little bit of ear fullness on one side, or maybe some mild pressure on one side, or they may have more severe symptoms, which is maybe eye related.
Mm-hmm.
They might notice that one of their eyes over time looks a little bit different than the other side. Maybe it's a little bit sunken back or a little bit lower than maybe what they remember it used to be. And they can be picked up on pictures even before people notice it themselves. They might notice it in pictures of themselves, a little difference in their eyes compared to what used to be.
Yeah, it's
Yeah.
wild, but as Dr. Reddy was just describing, because the sinus is obstructed, and again, to remind the audience, like this is not something that happens in a week or 2 weeks. I try to remind my patients this probably process has been going on for years and sometimes decades to create what Dr. Reddy was just describing, which is kind of this either enophthalmos or starting to shrink down the maxillary sinus to the point where the orbit starts to sag.
Yeah.
So very frequently, I don't know what your experience is with getting ophthalmology involved, but
Yep. Yep. Sometimes you have to get ophthalmology involved. But the reason why this happens that we think is because if the sinus is obstructed completely, then there you have chronic inflammation in your sinuses, and the mucus and the pus that's there can't get out of your sinus into your and drain properly into your nose. And so the thought is that maybe that chronic inflammation causes your body reacts to that in a way that it actually kind of contracts that area by it's trying essentially trying to protect itself from having that infection spread to other areas, and eventually that sinus kind of contracts a little bit, and then when it contracts, the eyes which are around the sinus kind of get displaced and moved from their original position.
yeah. So we talk about those sinuses as being that trauma cushion around the eyes and underneath the brain. So if that trauma cushion starts to contract, those areas around it, the eye and the
Mm.
brain can start to get kind of displaced or moved because of it.
Yeah.
Um, and so these are something that typically in the past would have always been treated under general anesthesia in the office, but we're doing more and more of these. Not that they are extremely common, but when we have these, we're able to offer more minimally invasive or less invasive tactics to try to accomplish the same result. One thing that we sometimes see, especially in the cheek sinus, is patients may develop an allergic fungal ball in that sinus because of it being obstructed for so long. They get this kind of thick gel-like peanut buttery type of drainage in that sinus, which won't come out very easily. Dr. Reddy's fantastic with these, but does a lot of these where do you want to talk a little bit about like usually we would do these massive openings, but now because of some newer technologies, we're able to do smaller openings and do some other things to help get that stuff out.
Sure. So, in the past, you would have to go to the operating room under general anesthesia and open things up really widely to kind of clean out all the disease. But now, oftentimes, like, your patient example is from Marlton, right?
Hmm.
And she was previously potentially, thought about getting sinus surgery that's more big and more aggressive done under general anesthesia. She was able to get her procedure done in a more minimally invasive way in the office setting. Now, it's not for everybody, but for some people, when the anatomy is favorable and you can get things get it done in the office, it's probably preferable to do it that way. One actually nuance I wanted to go over between silent sinus syndrome and um, most of the patients we see, which is just chronic sinusitis, is that most patients that have chronic sinusitis, when they're kind of deciding whether or not they want to get surgery or sinus procedures, it really is based off of how much the stuff bothers them, right? And so most people that get sinus procedures, they're getting it because their quality of life is really affected and they've really kind of failed what we call maximal medical therapy. In silent sinus syndrome, it's kind of the exception
Hmm.
because a lot of these patients come in with minimal to maybe even no symptoms. And then you're kind of trying to, you're talking to them about a procedure,
Right.
right? So, how do you counsel these patients that maybe have minimal to no symptoms and then, you're talking to them about potential surgery?
Right. So I typically talk to them about avoiding future complications. And so that's the big thing. As Dr. Reddy said, yeah, most patients get to a tipping scale where they're like, I need something done. And that's when they show up here, is when they say, I've dealt with this chronic sinus disease long enough. Now it's time for me to do something. This medication or everything I've been doing just isn't really cutting it anymore. Whereas these patients, it's often very difficult because they don't have significant symptoms. They haven't met a tipping point. It may be found incidentally. like Dr. Reddy said, like on another CAT scan or x-rays of something else for a dental procedure. So these patients really may not have many symptoms. So the counseling and talking to that I have with them is that we're trying to avoid future problems. And so these sinuses, as I mentioned, are trauma cushions around the eye and the brain. And so any infection that's sitting in those sinuses can spread, and it can spread to adjacent areas like the eye, the brain. And so we're, one, trying to avoid those things. And two, we're trying to avoid anything that may, especially with the eye, if it starts to contract and contract and contract down, the eye may start to drop. You may start to get double vision and requiring further procedures like an implant to be put in the eye. So a lot of times, if you can stop it early, you can halt the progression of this problem and then avoid needing further things down the road.
Correct. Especially if you develop eye problems, like correcting that later is very
Bigger
very
problem.
difficult. Yep. But I think that's all we have, right, for today's
Excellent.
episode. And what we're also going to be doing on this episode is hopefully connecting some of the CAT scan images on the video feed. So if you want to see what the CAT scan looked like on this patient with silent sinus syndrome, check out the video version of the podcast. Take care.